let's get started. Perhaps, Cora, I'll start with you, right? Maybe we'll start first in this post-salvage setting. So patients with non-metastatic hormone-sensitive disease, right? We got news earlier this year, I guess, more news on that in regards to the addition of ARPI enzalutamide to ADT for patients who come, who don't have an opportunity for a cure. So they underwent surgery or radiation with definitive intent or salvage. And then they have rising PSA, the definition of recurrence can be different, we have that question all the time, right? We see those patients have recurrent disease, and we got to think what we're going to do with them. So before we talk about treatment options and how we all think about those patients, maybe I should start you first. Let's start first by, how do you see those patients as far as risk stratification? Because in my clinics, right, some of those patients take years to get for the PSA to double, right? And sounds like the right thing to do is actually hold tight. Other patients, you can tell disease is moving, and we got to do things faster. So do you agree with that? Do you have any kind of process in your mind that you can walk us through about how you stratify the patients that come to you with this post-salvage setting?
I mean, if we have elderly patients who have already had radiation or prostatectomy and radiation, and their doubling time is very long, we might just observe those patients, depending on their age. The EMBARK study is something that we've heard quite a lot about, but that's a select group of high-risk patients with a doubling time of less than 9 months. And that's important to realize that who we're talking about when we talk about the EMBARK study. And that was a very good, perhaps practice-changing study in which patients with PSA doubling time less than 9 months were randomized between ADT alone, between enzalutamide alone, monotherapy, or enzalutamide and ADT. And what they found was that patients either with enzalutamide alone or with the combination did better than ADT alone. And they gave it for a certain amount of time, and they saw how well they did at a certain amount of time. I believe it was 37 weeks. And if they did well, then they would stop the treatment. And they found that the ones who, that both the monotherapy, enzalutamide, and the combination arm had better response rates and did better than the ADT alone. But if the combination arm actually stayed off therapy for a longer amount of time once it was stopped. The monotherapy arm, though, is very attractive to many people, though, to not go on ADT. But there are differences in quality of life. One would think that the monotherapy would be much easier, but there were quality of life issues even with monotherapy. Gynecomastia was something that we're not so used to seeing with enzalutamide. And so I think if people are going to be on enzalutamide alone, one of the things to think about is perhaps prophylactic breast irradiation. And I think that's one of the important things to think about with that.
Thank you for that, and I mean, I would agree completely. Talking about this space now is almost like, let's talk about the EMBARK space almost, right? Because it's for the first time we've seen how a very active anti-androgen added to ADT with the results you just summarized. So Andrew, maybe let me ask you. You look at the eligibility criteria for EMBARK, right? And I guess Cora mentioned the doubling time. The PSA at entry is different depending whether you're coming out of radiation or coming out of surgery. Is that the two factors that you use when you're considering subsequent therapy, or you think of other things? Other folks might think of Gleason score, T-stage, other known as poor prognostic factors that we used to talk, right, when we had this long-term natural history of that disease. So are you taking any other factors beyond the eligibility criteria? Like, what are your thoughts to address
that's a great question. I would say the disease factors that are critical are, like you mentioned, the doubling time is critical, but it's not a clean cut at 9 months. The faster it is, the worse the prognosis, the shorter the time to metastases. The time since your local therapy is an important prognostic factor. A guy who relapses within a year of surgery is going to do worse than a guy who relapses a decade after surgery. So that 3-year cutoff is prognostically important, and that's been validated in large natural history studies that go back 20 years. So the PSA level itself, the median PSA when metastasis appears on conventional imaging is somewhere around 20 or 30. A lot of patients don't realize that, but on PSMA PET imaging, it's a lot lower. So you can pick up metastatic disease based on the PSA. So the PSA level does play a role at when you might pull the trigger to start hormonal therapy or perform a PET scan. A lot of the EMBARK patients probably were PET positive, if you had that accessible during that time. And the Gleason score is important. Poorly differentiated tumors are more likely to be more aggressive. Those are the disease factors. Host factors, patient factors, really important because patients bring with them that decision point, their preferences. Maybe they've had ADT before, maybe they have frailty, comorbidity, preferences, cardiac disease. Intermittent therapy has been a long-standing standard of care for these patients to kind of optimize disease control on one hand and minimize toxicities on the other hand. And so EMBARK kind of builds on that intermittent approach, but with more intensive doublet therapy.
Right. I love that. That's a great summary for us. So Evan, just kind of, Cora alluded to the monotherapy arm. I think that's one of the uniqueness, the unique aspects of EMBARK is the fact that it provides a non-castrated arm, right? And I would argue actually the testosterone levels for those patients are probably higher, right? So interesting to hear your thoughts about, number one, there are many patients who come to you and say, Doc, whatever you do not castrate me, right? And so how do you approach that? Cora alluded to the specific safety profile or I guess adverse events that you do expect, which is different when you're castrating them than when you don't. So we're not as much used to that, right? Compared to in the metastatic setting, we'll talk in a minute. So how do you really look at that? And by the way, efficacy-wise, it looks like that arm actually did better than ADT. So, so my thoughts are, my question to you is, how do you approach that? How do you bring it up in your clinics to a patient? And how you decide between, enzalutamide monotherapy, enzalutamide plus ADT for the 37 weeks followed by the break? Can you walk us through that?
Yeah, sure. So I think, explaining the situation of the patient is the most important thing. The patient needs to know what he's getting into. So if you look at the adverse events profiles, if you block the androgen receptor and you don't give an LHRH therapy, you actually expect testosterone to go up. And as a result, that's where you get the gynecomastia, the mastalgia, et cetera. On the flip side, you can get some quality of life benefits with, potentially decreased sexual side effects, decreased hot flashes, which can be beneficial as well. So having that discussion in advance with the patient is the most important thing, and making sure that the patient knows what he's getting into, I think is the most important thing there. I think the real key question here, however, is when do you pull the trigger to do it? And that requires a lot of fine nuance in this disease state because there's a lot of heterogeneity in this disease state. There are patients, as you mentioned, that have a great prognosis. They're going to do really, really well. And maybe, those are patients that not only do you not need doublet therapy or enzalutamide monotherapy, they may need no therapy, or they could even just do traditional intermittent androgen deprivation therapy, as Andy alluded to. Because intermittent androgen deprivation therapy back in the Juanita Crook New England Journal PR7 trial days showed that intermittent was non-inferior to continuous therapy with a median survival of almost a decade and median time to castration resistance of almost a decade. So as Cora alluded to, taking age into account, taking comorbidities into account, taking in a patient desires into account, counseling on all the adverse events, that's how you're going to decide. I don't know that PSA doubling time 9 months is the end-all, be-all. Maybe it should be 6 months, maybe 3 months. 3 months is a no-brainer for me. If I have a patient with a PSA doubling time 3 months or less, their prognosis is very similar to somebody who has metastatic disease by conventional imaging. That's somebody where I feel like, yes, I need to do the EMBARK method. But if their PSA doubling time is longer, it's an active discussion, not just about the adverse events of monotherapy versus doublet therapy of androgen deprivation with enzalutamide, but do we even treat, and when do we treat? So it's got to be individualized because there's a lot of heterogeneity in regards to outcomes and prognosis there. And just as we want to have great outcomes for our patients and delay, bad outcomes from cancer, we also don't want to overtreat and affect quality of life negatively.
Right, for sure. That's a fantastic point that you're making there.